AIOS Dr. S.S. Badrinath 2021 Endowment Lecture to be delivered by Dr. Taraprasad Das. Dr. Natarajan sir, can you please introduce?
Yes. Thank you. It's a great pleasure to introduce my mentor. And I think as everybody does not need introduction, but I think Dr. Gullapalli Rao is here, I think. Nag, you are there. And I remember it's a very a very disturbing trend. And I am glad Dr. Partha started this. The disturbing trend is there is a book called Third Death, which Dr. Nagpal always tells me. Usually the grandchildren will remember the grandfather, then they don't remember the great-grandfather. And then the public figure, he says, one generation remembers. Gandhiji is the only one who remembered 3 generations or 4 generations. And then now I think everybody says 2nd October is a holiday, and that's all they know. So I think Dr. Nag told me that nowadays people don't know who is Dr. Badrinath and who's Dr. Venkateswamy. And I think that he told me in a conference in International Uveitis conference in Goa, and Narsingh Rao was there. So I think the sessions are important for ophthalmologists who are training now and getting graduated. So Dr. Badrinath, my guru, Chairman Emeritus of Shankarnetha, born on 24th February 1940. We had, I think, that particular year, Dr. Namparamal Swami and Dr. P.N. Nagpal. And he is the founder of, chairman of Emeritus of Shankarnetha, one of the leading eye hospitals of India. He is an elected fellow of National Academy of Medical Sciences. The words of Shankaracharya, the need to create a hospital with a missionary spirit, inspired him to start a charitable hospital. And Shankaracharya told him that one Badrinath should become 1,000 Badrinath. And Sengamedu Srinivasa Badrinath was born in Triplicane, a suburb of Noida. It's a main part of Chennai. His father, S.V. Srinivasa Rao, an engineer, was employed in Madras government. His mother, Lakshmi Devi, was the daughter of an advocate from Tamil Nadu. Beginning his education late at age 7 due to a child illness, Badrinath studied in a PS High School and Sri Ramakrishna Mission High School, and his complete his college education at Loyola College, 1955 to 1957. He lost both his parents while still in his teens and completed his medical student and the insurance money obtained from following the demise of his father. He graduated from Madras Medical College. I'm glad that many of us, including Dr. Venkateswamy, Dr. Myself, we are all alumni of Madras Medical College, which is more than 190 years now. And he did his internship and a year of internal medicine residency at the Glasslands Hospital, New York. Following the study of basic sciences and ophthalmology in New York University, he became a fellow of the Royal College of Surgeons, Canada. He worked with Dr. Charles Stephens at the Retina Service, and Charles Stephens, same where Dr. Nam also was trained, and father of modern retinal detachment surgery. And he returned to India in 1970, and from 1970, for a period of 6 years, he worked at the Volunteer Health Service, Chennai, as a consultant. He set up private practice in ophthalmology and vitreoretinal surgery at HM Hospital and Vijaya Hospital. And at HM Hospital, he had a consulting room, and the next room was Dr. P.C. Reddy, the founder of Apollo Hospital. And I had the opportunity to see him in 1970 when he came, and I was in 7th standard, yes. And thanks to my father and grandfather who were ophthalmologists, so Dr. Venkateswamy used to tell, he knew my 3 generations. So he's the founder and chairman of the Emeritus of Shankarnetha, and this Temple of Eye with more than 300 crore hospital now, and that's not important. The whole thing is serving selflessly without any caste, creed, or religious consideration, ranked number 1 for eye care in India. And you can see him. He came to release the book called Inside, which was in Mumbai, and all people in Mumbai adore him because most of the Gujarati and Marwadi from Mumbai have given the donation to Shankarnetha. And he has accolades, Padma Shri, B.C. Roy, Paul Harris Fellow Padma Bhushan, and many others. And one of the most important is he was the one top 25 people in India awarded by the NDTV Award. And the Retina Hall of Fame is established by the American Society of Retina Specialists to honor many talented and dedicated individuals, these physicians, scientists, and related healthcare workers over many centuries and countless generations are devoted to their professional lives to innovation, research, and clinical care in the field of retina. They have saved many from blindness and improved innumerable lives. And I always salute him as a Mata, Pita, Guru, and Mitra, and Deva. And as Retina Hall of Fame was established in 2016, they inducted 242 chartered inductees. And I'm happy to say there are 2 from India in the charter members, where it is starting from 1851 to 2016. I'm glad these are the individuals with significant achievements in the Retina Hall of Fame. And there are 2 Indians in the charter. I'm happy the teacher and the student are there, and that's me and him. We made a dedication in 2015 as the 75th birth anniversary of birthday celebrations of Dr. Naparma Swami, Dr. Nakpal, and Dr. Badrinath, who are the main people for spreading retina here in the country. And this is a short video, and you can see Dr. Badrinath and Dr. Golapalli Rao are here. And so his message is not by penance, not by visiting holy rivers, not by reading scriptures, not by chanting mantras, but by only performing selfless service to humanity, one can cross the ocean of life. And he's a great supporter for all his students all the time. So this is a book I recommend people to know. It's a concise mastery by Richard Green. And when learning a new skill, there comes a point of frustration where we quit on ourselves before we actually give up. And Dr. Badrinath is a great teacher. Learning and mastering a skill requires practice and therefore time. As humans, we tend to shrink away from anything that seems painful or overly difficult. And I think all the painful moments when we were trained with Dr. Badrinath I think it's a pleasant journey. I'm sure Dr. Gopal, who's here, who's an ardent student of Dr. Badrinath, will agree. And thanks to my 3 generations, my great-grandfather was known to Dr. Venkateswamy and my father. And I take this opportunity to introduce Dr. Badrinath, who could not be here, but I think it's a great pleasure to be here. And over to you, Dr. Partha. Partha? So Dr. Taraprasad be introduced by Dr. Chakrabarti, Arup Chakrabarti.
No, I
Rajesh will introduce Dr. Taraprasad Das.
Okay.
Yeah. It's a matter of great honor for me, and I'm really thankful to Dr. Partha Viswas to have given the opportunity to introduce such a legendary figure like Dr. Taraprasad Das, who is currently Vice Chairman of LV Prasad Eye Institute. He is also Professor of Ophthalmology at Sun Yat-sen University, Gunjau, and at various other positions in various hospitals like University of Rochester Medical School, etc. And there are various other medical schools wherein he is working as honorary professor. He is a stalwart in vitreoretinal diseases and has published 309 papers in peer-reviewed medical journals, index of 31, citation of 4112. It's huge. He has written 51 book chapters and has authored and edited 11 books. He has some current leadership positions at present, which includes the Vice President, Asia Pacific Academy of Ophthalmology, APAO, which is a matter of great honor for all of us Indians. He is also the chairman of Universal Eye Health Program Empowered Committee, Government of Odisha. He is also a member of Dr. APJ Abdul Kalam International Foundation and advisory board of various other organizations. And I would just like to be a little short because otherwise we will not be able to hear Dr. TP Das. We want to hear him more and more, because he has delivered 21 eponymous lectures, has received many awards, which includes awards from American Academy, the Asia Pacific Academy, the APVRS, the ARVO, the IAPB, etc., and so many more. Dr. Das was conferred Doctorate of Science, Ravishar University 211, and Government of India conferred the highest civilian award to him, Padma Shri, in the year 2013. And it's a matter of great honor and fortune for all of us to have Dr. TP Das here and to listen to him. So without much ado, I will request Dr. TP Das sir to please take over.
And we are also proud he's a past president of All India Ophthalmic Society and contributed to our AIOS. Congratulations, TP.
Thank you. Can you see my slides?
Yes. You have to make it full screen.
I'm doing it. Thanks, Rajesh, for kind, generous words, and thanks the AIOS leadership to consider me to worthy speaker for the prestigious Sengemudu Srinivas Badrinath second lecture of the AIOS series. In 1980s, I was living in Madurai, working in Arvind Eye Hospital, and between my two trains, from Madurai to Orissa, I had used to have 8 hours of layoff time. And I had a special arrangement with Shankar Netralia, particularly with Professor Badrinath, that in between I will visit him. And my way was that from one station, go and keep the luggage and go straight to OR. Chandran Abraham used to help me. First time when I went, I was given a printed paper, the OR etiquettes. And the first etiquette was wash your feet. And when I entered the OR with the change, the OR clothes, the first thing I noticed was they locked the door, and I was told by Professor Badrinath that you cannot leave before the surgery is over. That was in 1980s, before the stellar paper of a Mark Speaker on use of betadine. The country India did not have a powderless disposable gloves, so it was science of how to prevent infection in the eye, particularly endophthalmitis. He used to work very hard, and one time I asked him, one of my business asked him, I was more courageous to ask him that, did you get tired doing this surgery? And he told, no, I never get tired, I only get exhausted. So I learned from him that exhaust yourself to improve the world. So unlike other speakers, I will not speak about my philosophy, I will talk only pure science. I am fortunate, Professor Badrinath, I am giving a lecture in your name. I will talk about understanding the signs of fungal endophthalmitis. Reason is that endophthalmitis is not a very important subject from many point of view, but it happens very badly. And all of us are, at one point or other, if a surgeon, we certainly get affected by that. Fungi, as you all know, are eukaryotic organisms, eukaryotes all over the world. We have got roughly 5 million bugs, fungi all over. They grow everywhere, but you do not get infected as much as you should. And why so? Why? Because I got innate mechanism of the body. It creates a lot of phagocytosis and pro-inflammatory cytokine to prevent these bugs. That could be some of them, many of them are actually opportunistic or commensal, some of them are could be pathogenic. So the body prevents fungal infection in the body and the eye. Endophthalmitis is an inflammation of the inner layer, particularly the vitreous, as is shown by a borrowed slide from Dr. Radhakrishnan. That the vitreous grows all those micro or ocular abscesses inside the eye. Pathologically, they are, if you do a histopathology, normally enucleates the eye in India, they only give the eviscerate specimen. You can see a lot of inflammations are highlighted here, and you can see in the GMS staining a actual organism, filamentous fungi growing inside the vitreous cavity. What happened? The slide is not moving now. Something happened. The slide is not moving. Hello. Okay, now it's moved. I will talk about 3 fungi only because they are the most common fungi in our country or in the world. They are Aspergillus and Fusarium, both are filamentous molds, and the Candida, which is an yeast. And this shows both in the left side the culture and the right side microscopy how they look like. Why are they also important? Because we just submitted a paper about the analysis of 730 papers collected all over the country, from Delhi to Madurai and from Pune to Guwahati. It doesn't matter whether it's a post-op or trauma or endogenous. Aspergillus endophthalmitis is the most common fungi, followed by Candida for endogenous and Fusarium for other species. So that is why let us confine to these 3 organisms. We also published several years ago that in India, I reported up to 17% of fungal endophthalmitis compared to what published in EVS or ESARS or even Singapore. Incidentally, China has also reported closer to 13% of fungal endophthalmitis. So it's very important for us, even though it happens less often than bacterial endophthalmitis. Clinical diagnosis is very important. That the telltale signs that you can diagnose clinically were that small amount of hypopyon, but a lot of stormy corneal edema and vitreous exudation, or fungi adhering to the intraocular lens, fungi ball behind the pupil, or this kind of a inflammatory choroidal lesion sitting on the retina. Unfortunately, treatment options, available drugs are very few. They're mostly amphotericin B and voriconazole. When we're systemic, you can have some other azoles though. Because there are less number of drugs available to us, very careful how do you diagnose and how do you treat. This is the classical picture, the classical slide that what you have got, and only natamycin is available commercially. Suppose you prepare topical, then topical amphotericin B or voriconazole has to prepare with a shorter shelf life. So in case of preparing some, be honest that you cannot keep longer than certain period of time. 3 pictures I'll show you. The pre-operative 64-year male, 5 months after cataract surgery, comes with a little hypotonia student first picture. After 3 surgery, intraocular lens explantation, and 3 intravitreal injection antifungals, systemic antibiotics, systemic antifungals, patient ultimately gains in 3 months' time to 20/50, 6/15. There's similarly a trauma, fungus ball behind the pupil, required 3 surgery lensectomy, yes, but required 14 injections and systemic antibiotics to improve to 20/60 by 3 months' time. And finally, the endogenous, where patient required also several injections, which means that one has to be, while diagnosing clinical, one to be very patient about treating and inform the patient that require several treatment sessions to improve something. And even then, outcome is not as great. This paper, which is submitted also, so that depending on the post-op or trauma or endogenous endophthalmitis, not more than 20% people at the end of huge number of surgeries and procedures will not get more than 2,200 or so. And 18% of them could be no light perception. And same thing true for Aspergillus or Candida or Fusarium. This is 730 patients, so it's very large real world data. Compare this with the bacterial endophthalmitis, and we published in 2005 that 20% of them had at least vision of 20/40 and 60% have a vision of 2,200. So compared to bacterial endophthalmitis, fungal endophthalmitis, outcome are poorer despite a similar kind of treatment. So scientifically speaking, how do we change this? Because you have up to 17% fungal infection, you must know how to use the science to it. Signs in the horizon, to my mind, are inflammatory markers, next generation sequencing, real world data, which can actually help improve the outcome of fungal endophthalmitis. We published two years ago that fungi also reside on the conjunctiva. This not only does this some kind of genera like this or phyla like this, Ascomycota, Basidiomycota, Zygomycota, but also the common fungi which actually infect the eye, like Aspergillus, Candida, and Fusarium. So these guys are all opportunistic sitting in the conjunctiva. Unless they're prepared to protect the eye properly, they can cause infection. And we also have shown that in a so-called culture negative endophthalmitis, when you do a targeted next generation sequencing and hit mapping, then a lot of Aspergillus or Candida actually grow, even though culture is negative. This also, luckily, we have today betadine iodine, published in 1991 by Mark Speaker, that also killed the common fungi in less than 30 seconds. But unfortunately, when you do the survey of Indian ophthalmologists, where over 4,000 ophthalmologists responded, unfortunately, in 2017, at least 14% of the ophthalmologists in India did not believe or did not use povidone iodine as a preoperative preparation of the eye. And this should be told everybody, should be a kind of standard of care that is very important to prevent endophthalmitis. We also saw that in 25 years of Histopathology practice, culture negativity has increased from 50% in 1990s to 69 or 70% in 2015. What has actually happened? We being a referral center, patients who actually receive injections and come to the hospital. So that is why many times culture will not grow, and sometimes fungi will not grow because it's difficult to grow. And we thought about how the culture negative endophthalmitis is working. We reported also 2 years ago that if you culture those by the next generation sequencing or a through output of microbiology, molecular microbiology, actually fungi grow even though they are culture negative. Look at the inflammatory markers. Fungi cell wall, the cartoon, has got 2 important things, some kind of protein, melanoproteins, and some kind of glucans, so 1,3-D beta glucans. These 2 can be used to produce, to use inflammatory markers. So we just submitted the article that by using the using the GM as an inflammatory marker, the area under the curve is very high with high specificity and sensitivity, and same thing about beta-glucan. So possibly these results are available in 2 to 3 hours time, and unlike a culture take several weeks. World is going to change with the real world data and real world experience. Unfortunately, because of paucity of patients of particularly fungal endophthalmitis, and because that is very expensive to do a randomized controlled trial, world will completely depend on the real world data and experience. And today, with the introduction of electronic medical record system, which Professor Nachia alluded to in the beginning, is going to be the main thing. Now, how does it differ? Ideal is always in RCT, and what RCT does, RCT asks a question, randomized controlled trial, you ask a question and answer it. If a question can be answered by RCT, which could be ideal, by using the real world data or the big data, one can think about alternately to answer through a target trial. Target trial is going to be the future of ophthalmic care, or replacing ultimately the randomized controlled trial. This I got from Professor Lingam Gopal, and I asked him that give me a quote which I would like to quote for Professor Badrinath. And I told this, which actually Nagra always speaks about this: do this for your patient what you do for your own relative. It's very, very important, very, very important statement, because that is how one should always treat your patients. Globally, over 300 million people are affected with a serious fungal infection. Many of them invasive fungal infection like aspergillosis, candidiosis, fusariosis. 25 million people, at the estimation of 2018 by WHO, at high risk of either dying or losing their sight. Unfortunately, fungi do not always grow in the culture. Histological differentiation, identification challenging because it require a very high flown laboratory and a acute pathologist. In that situation, we have different opportunities. There is no global report on fungal endophthalmitis like a bacterial keratitis or bacterial endophthalmitis. There is no randomized controlled trial. There is no universal treatment protocol like EVS we have for bacterial endophthalmitis. This throws up opportunities to test new technology like molecular microbiology, targeted next-generation sequencing, and real-world data. And real-world data are going to be the real factor. While doing this, must be aware that because there are lesser number of antifungal agents available to us today, and newer ones are not being made very quickly, will take several decades maybe, one must be very careful to avoid resistance and think about the antifungal stewardship, like we have got antimicrobial stewardship, because you can't afford to have resistant bugs to the few drugs that you have today. That is why, my friends, understanding the science of endophthalmitis, science of fungal endophthalmitis is very, very important. Natarajan talked about the book release. It showed a photograph where Professor Nagpal was there, and this is the real book of insight by Sankar Nethralaya. Talks about the compassionate care that Nethralaya does, and then at the same time, those of us who are interested in learning a little more endophthalmitis than what you normally have, and I suggest that the book edited with several people called Endophthalmitis Guide to Diagnosis Management. This could be one book which can be possibly help the young residents to understand more about endophthalmitis.